Welcome to one more lecture of neurology. And this lecture is about neurodegenerative conditions of CNS. Now, first of all, I would like to mention that neurodegenerative conditions are a lot in neurology, and of course, too hard to sum up all of them in one lecture, and some of them are beyond the scope of uh, undergraduate students. So, I will be talking mostly about two very common type of neurodegenerative conditions which can occur in humans. So, what is neurodegenerative conditions? Neurodegenerative conditions are, or what is degeneration? It is simply loss of structure or function. So, neurodegenerative means what? When there is loss of structure or function of uh, of neurons, right? So, and now this loss is progressive, and of course, like the sign and symptoms, they started appearing over the time of years, you can say months to years. Okay, so yeah, simply, what are the neurodegenerative conditions? uh, Generative conditions in humans or in neurology, because we are studying neurology right now. So now, as I told you, there are many neurodegenerative conditions. Um, for example, Parkinsonism, which is very common. And if you will visit any neurology ward, like there is like there is high chances that you are going to find patients with Parkinsonism. So Parkinsonism or Parkinson's disease is a neuro Parkinson's disease is a neurodegenerative condition, right? But um, we can also classify Parkinson's disease under the heading of movement disorder. So, like that disease, we can cover in movement disorder. So, many conditions are there. Huntington disease is there, Parkinson's disease is there, amyotrophic lateral sclerosis, or what we can call it as motor neuron disease. So, what are the conditions like uh, motor neuron disease is there? Okay, this is called as MND, or the most common type of among motor neuron diseases is like amyotrophic lateral sclerosis. Parkinson's disease is there. Then there is Alzheimer's disease is there. Okay, Alzheimer's disease is there. So there are different conditions. Huntington disease is there, and many more are there, right? So simply, uh, what's going on in all these conditions? Like there is loss of neurons, loss of structure and functions of neuron is going on. Okay, and that's the reason that when there's loss of structure and function of the neuron, there is some clinical features which occurs. So, for example, in Alzheimer's disease, there is loss of neuron and synapses in the cerebral cortex and subcortical region, which results in atrophy. And there is degeneration of the parietal lobe, temporal lobe, and the patients, they present with signs and symptoms of dementia. Parkinson's disease. Sorry, I'm saying again and again, Parkinson's disease. Okay, Alzheimer is very common. The most common one is Alzheimer. Parkinson's disease is the second most common neurodegenerative condition. And again, this one is like when the neurons uh, function and structures are lost in the uh, basal ganglia. Okay, and Huntington disease is also there. Amyotrophic lateral sclerosis is also there. So there are many names of amyotrophic lateral sclerosis. It is also called as Lou Gehrig's disease. Okay, so and many more are there, of course. Like okay, so of course, like in this lecture, we can just talk about two conditions. Uh, One is MND and one is Alzheimer's. To tell you, like nowadays, they are using a new type of classification, like they classify them the conditions like as movement disorder, which like under which they uh, categorize Parkinson's disease and Huntington disease, like because they give some movement problems. And then they classify the condition as mild neurocognitive disorders. Mild neurocognitive disorder. So simply when the cognition is disturbed. Okay. So the, as you know, what is cognition? Like these are the, what you can say, the higher functions which are done, or which are done by our higher cortical area. And then there is major neurocognitive disorder, which formerly, like previously it was called as dementia. Alzheimer's come under this thing. So cognitive function, one thing which is very important to understand here is cognitive function. What is cognitive function? Because when we discuss Alzheimer's, then you must know what is cognitive function, because these are the things which are lost in this one. So, there is ADLs and IADLs, or what is ADLs, like activities of daily life, and what is IADLs, it is instrumental activities of daily life. So, uh, what we do is like, yeah, what we do for our daily living, uh, like we eat, we move around, we do toileting, we do hygiene, we do grooming. Okay, so that comes under ADLs. Okay, uh, activities of daily life. So uh, like in neurology or in rehabilitation, you are going to um, read a lot about uh, what is ADLs and what is IADLs. So to talk about what you can say more about ADLs, ADL is like we need we have to eat to live, right? So what we do is like um, for example, someone who cannot who have some stroke, who have stroke, okay, and they cannot swallow, or like their hands cannot move, so they cannot self feed themselves. So it means like their activities of daily life is lost, right? We go and we keep ourselves clean, or simply we do shower every day. So that is also activity of daily life. And then we groom ourselves, we brush our teeth, we brush our hairs, and uh, all these things, they come in grooming or personal hygiene. Then we dress up, okay, so that is also activity of daily life. Then we can go to the toilets or locomotion, like so when we go to the toilet, of course toileting is an activity of daily life, and to go toilet, of course, we have to move around. So our mobility is also activity of daily life. So this is in ADL, this is called as ADLs. Okay, and then there is um, instrumental activities of daily life. Okay, so what is instrumental activity of daily life, or IADLs? Is simply when the activities which we perform daily, and there are some instruments which are uh, involved in them. For example, you go for shopping, uh, that is an instrumental activity of daily life. You have to make calculations while shopping, you have to keep your money, you must know like how much money you have spent, how much money you are left with. Okay, and also like you can prepare a food, you can cook, of course, like to cook you use cooking utensils, uh, and if you are taking some medications, of course, if you can take them as well. So, or like you can drive, for example, or you can use your smartphone. So simply uh, these are instrumental activities of daily life. Or you can clean your home. Okay, now it's not cleaning about for yourself, like cleaning your home is called as they are included in activities, in instrumental activities of daily life. So simply uh, in neurology, when we have to see like how much, like after stroke or in neurology, we see like how much where the person stands. Either he can do instrumental activities of daily life, or either he can do activities of daily life. And this is the goal of rehabilitation as well. Like we have to rehabilitate the people so that we can bring back as much as ADLs or IADLs as we can, right? uh, So one of the thing, like if you will talk about Alzheimer's, is the cognitive domains which we have to check. Okay, so what are the cognitive domains? Like these are all the executive functioning which is going on inside your cerebral cortex, like uh, uh, learning, memory, language, all these things. These are like uh, your cognitive functions, right? So uh, what happens in Alzheimer's is basically, you can say that cognitive functions are the one which are lost. Okay, so when these cognitive functions are lost, so of course, like the person become dependent or things like this. Okay, previously it was called as dementia. So all these things, for example, uh, you acquire knowledge, you understand what other people are saying, you can think, or you have the intellectual thinking. You can memorize the thing, you can uh, judge the thing simply. Okay, or you can calculate, or you can solve problems, or you can make decisions, or what's your language comprehension and all this stuff. These are of course higher mental functions. Okay, okay, so we always check the cognitive function. Okay, so uh, of course, like uh, it's very hard to uh, like go in more detail of these things, of course, otherwise like we cannot uh, we're having no time to left to talk about Alzheimer's. So the first condition which I'll be talking about is Alzheimer's. Okay, okay, like Alzheimer's, as I told you previously, it was called as uh, like dementia. It was included as dementia, but now they call it as neurocognitive disorder. Okay, of course there is dementia in Alzheimer. So not just because of Alzheimer, but there is frontal lobe dementia. There is dementia with Lewy bodies. There is vascular dementia, and there are many other causes of dementia. Even like people who are depressed, they may have dementia as well. So previously, like it was called as dementia. Okay, it was characterized as dementia, but now they call it as neurocognitive disorder. So which makes of course like more sense, because the cognitive functions are those uh, which are lost, right? So that's the reason behind this thing. Okay, so to talk about Alzheimer's disease, guys, a very important thing. Um, Alzheimer's is it's a disease of old age, okay, and it's a chronic neuro degenerative disorder, okay, or disease. So, like, it is the most common cause of dementia. 60 to 70, like more than 80%, you can say around 80% of dementias are caused by Alzheimer's. Okay, and the most common symptom is like which appear in the start is like they become forgetful. They started forgetting the things. Okay, and of course, like as you know, memory is one of the function of like is one of the cognitive function. So of course, like as the time passes by, so they keep on losing other cognitive functions as well, like thinking and all these things. Okay, so of course, like the first symptom, most of the time the first symptom which appear is what you can say, they become forgetful. So Alzheimer's disease is very common, and it's a neurodegenerative condition. And what is there? By definition, uh, like you can simply say that it is Alzheimer disease is having insidious onset, and there is gradual progression of cognitive and behavioral symptoms, right? So by definition, um, what how they define this condition is like it's a condition in which there is loss of cognitive as well as there is many behavioral symptoms. One very easy way to remember Alzheimer's disease, like as you can see, AD, Alzheimer's disease. So remember 4 A's and 1 D. Okay, so what are the four A's? There is um, interrograde amnesia. Okay, like as you know that there are two type of amnesias. Okay, like what is amnesia? When someone, like, you cannot remembers event, right? We call it as amnesia. Okay, in medicine. So there is like two type of amnesia. One is called as retrograde amnesia, and one is called as interrograde amnesia. So what happened, like in these people, they have interrograde amnesia. So interrograde amnesia is basically, you can say, they found it hard, or they are unable to make new memories. Okay, uh, and what you can say, the previous memories, which are like in your long-term memory, they remain intact. Okay, whereas retrograde amnesia is inability to you can say recall memories before the onset of amnesia. So like this is the difference between interrograde and retrograde amnesia. So with first A, remember interrograde amnesia, as well as the second A, remember about aphasia, and third A is apraxia, and the fourth A is agnosia. But rather, I would like write over here. Okay, just to make you guys remember. So the first A is in interrograde amnesia. Okay, amnesia. Second A is aphasia. Okay, third A is apraxia. Okay, and fourth A is agnosia. Okay, agnosia. So agnosia. Okay, okay, and the one D which is left is basically um, disturbance in executive disturbance in executive functioning. Okay, functions. So this is how uh, they present with. So interrograde amnesia plus at least one of the other features. One thing should be this one plus one of the other features are required to diagnose someone with Alzheimer's disease, right? Now, you'll be thinking about what is aphasia. Aphasia is like, when someone cannot talk, okay, like the language problem simply. Apraxia is these are the people who have difficulty in performing movements, okay, or any task, okay. So, for example, uh, uh, you will ask them like to stand up or to give me a glass of water. So like they found it difficult to you can say start that thing. Okay, so like of course, like whatever we do, it's in our learning, we know like how to perform different tasks, but they are like they cannot perform because they have like uh, loss of disability, okay, to do some purposeful movements. There are different type of apraxias, like constructional apraxia is there. So what is constructional apraxia is like difficulty to draw. Okay, there is ideomotor apraxia. There is oculomotor apraxia, of course, like difficulty with eye movements and all those things, right? And agnosia is simply uh, when I was teaching you the brain functioning, I told you that uh, if you are going to put give someone in their hands and ask them to close the eyes and feel the thing and tell what's that. So we can basically recognize the things by like how they look like or how they feel. Okay, or like we can recognize the people by their sounds. Okay, so when someone who cannot process this information, which is called as agnosia. So simply, agnosia is the inability to process sensory information. Okay, so either it is in your hand, or either it is like you are seeing something or you are listening something. So like even apraxia, agnosia have a lot of types. Okay, auditory agnosia is there, and finger agnosia is there, as well as semantic agnosia is there. So there are many type of agnosia as well as apraxia. So again, like our discussion is going on different side. Like if I let's try like keep on explaining you these things, of course there will be no time left for Alzheimer's. So they say like we need one this for sure, and one of these four to diagnose anyone with Alzheimer's condition. So uh, like typical presentation of Alzheimer's patient is amnestic. Okay, amnestic. They become forgetful. Okay, so in the mild phase, what happened? Like there is impairment in memory and their learning. Sometimes executive functions are also lost, and there is a moderate or severe phase in which like they have this apraxia. Okay, as well as like language is also impaired. Okay, so simply you can say that there is a mild type or mild phase, and there is a moderate to severe phase. Okay, so how we can clinically how we can catch is like in mild phase they have just impairment in memory. Okay, uh, and some learning difficulties are also there. Okay, and in the mild to severe form, what happens is they have visual uh, visual constructional um, motor inability, right? Motor or apraxia, simply motor inability, and language problems. Language problems can be there. Okay, language is also impaired. So this is like how they present with. So Alzheimer's patients, how they present to the patient, like to the hospitals, is like first of all they become stressful, forgetful. Okay, amnestic. So they become forgetful. Okay, so uh, they don't remember the things. They started forgetting the names of their family members or friends. Okay, and of course, like it's not the patient who noticed this thing, but it is the people who are around the patient who started noticing this thing, that this person is becoming more and more forgetful. So uh, sometimes they will appear confused. Okay, and then like what happened, like as their disease become bad and bad, they started having problem with the sleep, and they have they will find it hard to execute the things which are already in their memory. Okay, like same thing, can you please do drive a car? So like they cannot. Okay, so but in the late stages, uh, even their thinking is lost. They cannot think, they cannot speak. They have aphasia, language problems. Okay, and they become, sometimes they become abusive, by the way, sometimes they become paranoid. Okay, so things can be there, and they of course like they develop a lot of other things, of course, as like their condition become worse. So this is like the typical presentation, and then there is what you can say that atypical patients are also there, or atypical presentations can be or can also be there. So atypical presentation is basically non uh, amnestic. Okay, of course, like uh, they their memory is intact. Okay, but what they have is like either you will found language disturbance, either you will found apraxia, or you can say inability to carry out motor activities, or either you will found agnosia, like failure to recognize or identify objects. Okay, so this thing, so this is the atypical presentations, right? So typical presentation there and atypical presentation is there. So basically, one of the thing, Down syndrome patients, they are are at increased risk of getting or developing Alzheimer's disease. Okay, what is the cause of Alzheimer's disease, guys? It is genetically related. Okay, there are a lot of genetic factors. Why? Because uh, this condition, you can say, pathophysiology, physiology of these patients is, genetic factors are there. Okay, genetic factors are there, and it is like most of the cases are basically autosomal dominant. Okay, uh, what they found, like they found at least three major genes with like in the people who have Alzheimer's, like one is on chromosome 21, one is on chromosome 14, and one is on chromosome 1. And what happened, there is a amyloid precursor protein, uh, amyloid uh, precursor protein. And what is the name of that protein? uh, like this amyloid precursor protein, they found it on chromosome number 21. And then there is presenilin 1, they found on chromosome number 14. And then there is presenilin 2, which they found on chromosome number 1. So they found like there are certain genotypes, who are uh, who are at risk of getting more Alzheimer's disease. So this thing is important. So what happened is, by the way, like Alzheimer's condition, the people who get Alzheimer's condition, when they, of course, when they die, okay, because of course we cannot take out the brain of a living person and we can see what's going on. So when the patients die, what they found is diffuse cortical uh, atrophy. Okay, and of course, like when the person is living, we can do a CT scan and maybe we can see the degenerative condition on the CT scan on MRI. Okay, so they found diffuse cortical atrophy of the frontal lobe, of the parietal lobe, of the temporal lobe, of the hippocampus, and all the structures. And when they see it microscopically, what they found is uh, they found senile plaques, okay, of you can say amyloid in the gray matter of the brain. Okay, so they found these things. Also, they found there is loss of synapses in the brain, as well as they found that there is uh, neurofibrillary tangles in the brain. What is neurofibrillary tangles? These are basically uh, inside the cytoplasm. There are some small particles, you can say, filaments, which are basically abnormal protein, which they found. Okay, and what they found, one more thing, is loss of cholinergic neurons. Okay, especially in the nucleus basalis. Okay, they found this thing. So this thing they found in the brain of the patient once the patient is dead. Of course, like all this research they did, like on the dead people, and biochemically, what they found is, you can say, up to 90% um, reduction of what you can say, choline acetyl transferase. Okay, so these are the things what they found in the patients who have um, uh, this one, Alzheimer's condition. So guys, this condition is very, very, very common, by the way. Like you can say the people who are more than 85 years of age, uh, more than 85 years of age, what they found, like 1/3 of them have Alzheimer's disease, right? So it is very, very, very common, and that's the reason you can say age is the largest risk factor. Okay, so it's a disease of old age. Okay, but like I, like I told you, like it is like the genes are associated or genetic factors are there. So many of the people who have apolipoprotein E4, okay, they get this condition well at younger age, uh, okay, like than the rest of the people. So many people, what they found is uh, many people who have Alzheimer's, they found a history of traumatic brain injury. They found family history. They found patients with Down syndrome. They have more. Alzheimer's affect more of the people who are not educated. They're like like they have never been to universities, okay, and they found like smoking, hypertension, diabetes mellitus, like they have some association, but like not very strong association. So like these, you can say these are all the risk factors. So clinical features, as I told you, for Alzheimer, and the clinical features, uh, in Alzheimer, of course, like there are three major things which are going on. Cognitive impairment will be there. Okay, then there will be some behavior problems. Okay, behavioral problems will start, of course. Okay, or behavioral manifestations will be there. Behavioral manifestations will be there. Okay, uh, there can be uh, of course, like psychiatric manifestations or behavioral manifestations, they are the same thing. And there can be motor manifestations. What is motor manifestations is like simply what I was talking about, apraxia, right? So talking about the cognitive impairment, what happens, like in the start they started having memory problems, they become amnestic in the start, and later on they have language problems, they have problem with reasoning, they have problem with all the executive functions which I talk about in the start, yeah, like even your language, or you calculate and all the things like this, right? So this is how they present, you can say. In the early stages there will be just they become forgetful, they become amnestic, and later on they have language or other cognitive functions are lost as well. Talking about the behavioral and psychiatrical manifestations, of course, like like all the conditions, like whenever anyone gets sick, okay, they become like there is a huge impact on the psychiatry of the patient. Okay, they become depressed. Okay, as well as many of the patients, they become psychotic. They are irritable. They become agitated. Some of them, they become too much aggressive, by the way. And like it's very common for these people to, like when they left the home and they, for example, they are going for a walk, they just forget like where is their home, and you will find them wandering here and there, things like this. Okay, and what are the motor manifestations? Again, it could be anything like gait disturbance, dysphagia, and all this stuff. Okay, so these are the clinical features for Alzheimer's condition. So of course, like once you have done the history, uh, uh, of course, like we go for examination, and most of the time on the examination we don't find anything in these patients. But like what you can found is maybe like to diagnose or to deal with the Alzheimer's, like it's very important to talk more about what you can say, uh, like psychoanalysis, you can say, right? So now, guys, investigations. Do you think we can do, like we can make a confirmatory diagnosis of Alzheimer's? No, because to make a confirmatory diagnosis of Alzheimer's, of course, what we have to do, we have to take out the brain, we have to see it microscopically. Okay, we can just do CT scan, for example, just to see if there is any um, degenerative condition is there, or like presentation is there or not. So of course, like basically, there are many causes of dementia, and the causes of dementia basically lie or how you can remember the cause of dementia. Uh, if you will Google, you will find uh, like the mnemonics, okay, for dementia, and one of the mnemonic is dementia itself, okay. So very easy, okay. By the way, I am googling the things, uh, just to say, see one of the like which I can see over here, one of the mnemonic is Wayne Shed, and there is one of the mnemonic which I like is dementia itself, right? So when we talk about the cause of dementia, D is for drugs, anticholinergic drugs. E is for emotions like depression. M is for metabolic or endocrinal causes. I is for ear and eyes problems. N is for normal pressure hydrocephalus. T is for tumors or any space occupying lesion in the brain. I is for infections like HIV or syphilis, and A is for anemia like vitamin B12 and folate deficiency. So one of the mnemonic is vitamins also. V for vascular, I for infections, T is for toxic or metabolite, A is for autoimmune, M is for metastasis, I is for iatrogenic, N is for neurodegenerative conditions, and S for systemic. So anyhow, whatever mnemonic you like, why I am telling you mnemonics here is simply basically dementia can be caused by many other things. So basically we investigate to rule out other causes of dementia, okay, or to check if there is any reversible cause we can found, so we can treat that, okay. So for example, someone who have dementia due to depression, we can treat their depression, we can reverse that condition. uh, Someone who have dementia due to infection, we can treat that. Someone who have dementia due to eyes or ear problems, of course we can treat that. So the investigations, like most importantly, is to check for any reversible causes, and if there is any reversible causes, of course, to reverse them. Then you can do EEG, very usually it comes back as normal, but sometimes there is slow waves are also seen. MRI is very helpful, guys, because MRI can show the atrophy of the hippocampus and the parietal lobe or the lateral ventricles, whatever is there. SPECT scanning can be done, okay, and what we can find in SPECT scanning is like hyperperfusion in the temporal and parietal lobes, and PET scanning can also be done in these patients. Okay, so see, like all the scannings can be done simply to do these things, but we cannot make a definitive diagnosis. Of course, to make a definitive diagnosis, what we want is to take out the brain and do like biopsy. Of course, like that is not possible. So talking about the treatment, guys. First of all, there is no cure for Alzheimer's. Okay, there is no cure for Alzheimer's. Remember this thing, right? So, what can be done? There are many medications which are nowadays which are used, okay, and they are basically there to slow down the condition, okay. And what we give them is acetylene uh, acetylcholinesterase, esterase inhibitors, okay, inhibitors. So if you know what is acetylcholinesterase inhibitors, like uh, what they do, like they basically slow down. Sorry, sorry. What is the function of this drugs? Like they slow down the progression, of the condition of the disease, right? They cannot cure, guys. Remember this thing. There are different drugs like which are in use nowadays in the hospital, like in the practice. One is called as donepezil. Okay, then there is rivastigmine, uh, rivastigmine. There is galantamine. Okay, so all of these are basically acetylcholinesterase inhibitors, okay, and they are used nowadays for treatment of not treatment, like to slow down the progression of uh, what you can say, Alzheimer's condition, right? So Tecrene also there, one more drug, but like many of these drugs are there, right? Which we can do. So basically, what they do, like there is reduction in the activity of cholinergic neurons, okay, in Alzheimer's, as we know. So basically, these inhibitors, basically, they stop the break, or they decrease the breakdown of acetylcholine simply, and there is the acetylcholine will increase in the brain, and of course, like that's the reason, like it can slow down the progression of the condition, right? So this is one of the treatment which we were like which we can add treatment option. Of course, acetylcholinesterase inhibitors cannot be given to people who have bradycardia or heart blocks, okay, as well as like anyone who have congestive heart failure or even asthma. We cannot give these drugs, of course, like so. Galantamine is a drug which we cannot give to anyone who have hepatic or renal failure. Okay. One more drug which is there is called as uh, mimen- mementine. Okay. So what is mementine? It is basically NMDA receptor antagonist. Okay. So mementine is NMDA receptor antagonist. Okay. So now basically what happens, and what is NMDA, by the way, it is N-methyl D-aspartate receptor. So this drug can also be used. Now this memantine is uh, like it is used in moderate to severe Alzheimer's condition, okay, but it is less preferred than the other drugs which I already talked about. Okay, so it shows like some benefit in these patients. Okay, and rest is all symptomatic treatment, guys, symptomatic treatment. And now the symptomatic treatment will come again and again, because when we will study Parkinsonism, I will talk about the same thing. Okay, so what is symptomatic treatment? Remember, like when anyone have any psychiatrical disorder, neurological disorder. So there are many other things which arises. For example, become uh, they become depressed. Okay, they have sleep problems. Okay, um, problems. They have sleep problems. Okay, now what happens? Like they may have other problems, like maybe they become agitated. Okay, or what can happen, like when we can give these drugs, of course, like they may have the side effects of those things, right? So there are many side issues which started arising. So what we can give for depressed people, of course, we will give them antidepressants like SSRIs, selective serotonin reuptake inhibitors. If they have sleep disturbance or sleep problems, we can give them some drugs to make their sleep better, right? So things like this, of course, we have to deal the um, side issues, and of course a lot of family support we have to provide, and they need economical support, they need many, like in developed countries you will find the people in daycare facilities and taken care by the aged care facilities and things like this. So uh, the mean duration of survival from the point of diagnosis, from diagnosis, is around 10 years. Okay, so of course, like it's a long time. So of course it's very hard for the people who are taking care of them to uh, like they need a lot of support. So that's why many of the social workers or community health workers, they help them a lot, of course, in the countries where the system is good. So uh, um, that's the thing, this is how this condition behave. Okay, and what you can say, we can send them to a psychiatrist or a psychologist who give them classes, or who like make them their willpower strong, you can say like this. So of course, like like this is about Alzheimer. Rest, like we cannot do anything to treat this condition, of course, because we cannot treat this condition, right? So this is all about this one, Alzheimer's. The next condition which we are going to study is called as motor neuron disease. Okay, so motor neuron disease. If I will to tell you, for example, uh, I can tell you a case presentation simply. Um, you are seeing a patient who have dysarthria. What is dysarthria? Like, you know, when the what you can say, uh, uh, someone who cannot articulate properly, right? This is what is dysarthria. So when they cannot articulate properly, so basically they have nasal quality of speech. So you found that there is wasted and flaccid tongue with prominent fasciculation. So see, wasted and flaccid tongue. So how it sounds like? It sounds like lower motor neuron type of lesion or bulbar palsy is there, right? So, uh, and there is palatal paralysis. Eye movements are normal. The upper limbs show proximal and distal wasting. So what's happened, like when you will see their upper limb, you found that the muscles proximally and the distal muscles are wasted with prominent fasciculations. Now, what is this one? Again, wasting and fasciculation shows lower motor neuron type of involvement. Okay, so uh, this thing is very important in this one. So what we are finding is a lot of lower motor neuron type of involvement, right? Until now. So uh, like then what you can found, there is wasting of the small muscles of hand. There is hypertonia and hyperreflexia. Now see, hypertonia and hyperreflexia are basically the features of upper motor neuron type of lesion, right? So see, there is lower as well as upper motor neuron type of lesion, and the sensations are normal, okay, because see, it is a motor neuron disease, so the sensations remain normal. And again, the lower limbs, when you examine, you found proximal and distal wasting with prominent fasciculations, but there is hypertonia and hyperreflexia, and you found ankle clonus, and you found extensor plantar response. So simply, what's going on is like we see a combination of upper motor neuron lesion with lower motor neuron lesion. Okay, so when you examine their upper limb, lower limbs, you found wasting, you found flaccidity, uh, you found fasciculations, which are lower motor neuron type of lesion or signs. But on the same hand, when you check the reflexes, you found hyperreflexia or hypertonia. And what are these? These are, of course, upper motor neuron type of signs. Okay, so basically, motor neuron disease or MND, okay, is a progressive disorder, is a progressive degenerative disorder, of course, okay, disorder, because we are studying that, which is characterized by neuronal loss at all levels of motor system. Okay, of course, from the uh, cortex to the brain stem. Okay, and uh, anterior horn cell. Okay, anterior horn cells of the spinal cord. So see, as the anterior horn cells are also involved, so that's why there is this physical signs of both upper and lower motor neuron type of signs, right? So signs are there. So like this is how the patients of motor neuron disease they present. Now there are different forms of motor neuron disease. Like one which we will study in more detail is called as amyotrophic, okay, lateral sclerosis. There is progressive uh, muscular atrophy. There is primary lateral sclerosis, and there is progressive bulbar palsy. Okay, now what are these basically? Um, I will explain you these things. So, as the name shows, okay, like this is the amyotrophic lateral sclerosis is the one which is also called as um, Lou Gehrig's disease. Okay, okay, guys, like neurodegenerative conditions are a lot. Okay, so see what we are seeing upper as well as lower motor neuron type of signs. Okay, and what happens is like there is degeneration of the neurons at all levels. So of course, if there is degeneration of neurons at cortex, it will be upper motor neuron type of lesion. Brainstem, upper motor neuron, anterior horn cells of the spinal cord, lower motor neuron type of lesion. Because there is disorder, so simply you can say, I can write over here, a very important point, by the way, like there is the disorder of anterior horn cells of spinal cord as well as cranial nerve nuclei, okay, and corticospinal tract. So this is basically what's going on. Like you can highlight this, and if you are good in the function of neurology or neuroanatomy, guys, it's a very very easy condition to understand. It's not hard at all. Okay, so amyotrophic lateral sclerosis, this one, which is also called as motor neuron disease or Lou Gehrig's disease. Of course, it is one of the type of motor neuron disease. Uh, so this is a very very important condition. Okay, so like ALS is the most common one in motor neuron disease. Of course, there are others as well. Okay, and what is the cause of this motor neuron disease, guys? It is not known, and the most common cause is basically idiopathic. Okay, so most of the time we don't know the cause; it is idiopathic. But 5% of the times they found some mutations in the genes, and they found this thing. Okay, and like this is how this condition present. So now I will tell you something. If you know this guy, Stephen Hawking, right? He's the one who had this motor neuron disease, right? And if you don't know this guy, then of course, like, I don't know, like, I cannot give you the example of anyone who is more famous than this. And NHS, the UK health service, they call it as their, um, you can say, really a big achievement, because they make this guy alive for a long, long, long period of time, right? So this is how this is like what is can say you can say the pathophysiology and the causes of this condition. So how these patients present clinical features, right? What are the clinical features? By the way, again, I can show you how motor neuron disease looks like, images. And okay, of course, like they are not showing any patient, but what I will be searching is for the patient. Okay, patient, see, motor neuron disease. See, a lot of wasting is there, right, in this patient. And anyhow, you can like see. So what is going on? See, there is upper and lower motor neuron type of things. So the one thing which which I wanted to talk about and I forget. See, this one is the most common type. Okay, amyotrophic lateral sclerosis. They have both upper and lower motor neuron signs. Progressive muscular atrophy are those who have um, predominant lower motor neuron signs. Okay, it is called as progressive muscular atrophy. uh, Primary lateral sclerosis have predominant upper motor neuron signs. Okay, and progressive bulbar palsy are those people who have you can say predominant bulbar involvement. Okay, like the bulbar, like it could be bulbar palsy or it could be pseudobulbar palsy. So this one have both upper motor neuron as and lower motor neuron signs, right? So these are the patients, okay, mitochondrial sclerosis. So clinical features, I already told you guys like how to remember the clinical features, right? I gave you the scenario. So how these patients present is like um, depending on like what type it is, you will found both upper and lower motor neuron symptoms, okay? So UMN uh, and LMN signs you will found, okay? If the patient have progressive bulbar palsy, so you will found dysarthria, of course, like in the patients who are the fourth type, okay? You can may have dysphagia, okay, as well as you can found tongue atrophy. See what's going on, because the cranial nerve nuclei, the one which are affected, okay? You can found fasciculations on the tongue, right? Sorry guys, this is dysphagia. Okay, so there you can found fasciculations on the tongue, right? So when there is like, this is the bulbar type, okay, and all those things. So sensations will be intact. Remember, sensations will, because it's a motor nerve nuclei disease, okay? So sensations will be intact, okay? Ocular muscles uh, will be normal, and sphincters, anal sphincter or urinary sphincters will be normal, okay? So like this, these are the clinical features of this condition, right? So of course, like then we go for investigations in these patients, and in investigations, guys, what are the investigations? We can go for EMG. Now, what is EMG? It is electromyography. So, uh, why we like, remember, whenever we have to check like either the problem is in the nerve, we go for nerve conduction studies, and whenever we have to found like either the problem is in the neuromuscular junction or the muscle, we can go for EMGs, electromyographies. So when we go for electromyographies, you can found chronic denervation or fasciculations. What happened like when we, if you remember, you have done these experiments on frogs. We take the frogs, we take out their one muscle with nerve, and we pass current in them. So the current in these people, when that we pass, they show positive sharp waves with complex repeated discharges. Okay, that shows like reinnervation. So this is how we found, okay, we can go for nerve conduction studies. So of course, like nerve conduction studies we do like just to rule out if there is any problem in the peripheral nerves, okay, or to rule out peripheral neuropathy. You can go for CT or MRI to rule out any spinal cord condition, any spinal cord compression, and things like this, okay. So of course, like in the clinical features, we keep on looking the red flags, of course, red flags like when the patient needs some help, more help, you can say. Okay, so we keep on looking for example, if the patient is developing any sensory symptoms, of course, think about other conditions. We keep on checking for any pain, any bowel or bladder incontinence, any cognitive impairment, any ocular impairment. Of course, like we whenever we found these things, of course, it's not MND. It should be something else. So that warrants more investigations. Okay. So how to treat this condition? Um, Treatment, of course, remember the neurodegenerative conditions, of course, they don't have any treatment, right? um, Rather, once they are started, of course, they stay like that, okay, the patients stay like that. So uh, to tell you like uh, the exact pathophysiology is not known because it is idiopathic, okay, and there are many hypotheses like toxicity hypothesis, free radical hypothesis. They found, like I told you, they found some genetic connections as well. in the patients, okay, to see like these things. So there is no diagnostic test. We can just rule out other conditions. So you can say it's a clinical diagnosis, okay. And if the condition affect the females, it's a poor prognosis. There is a, like, it means poor prognosis. If it is present in older age, it means like there is poor prognosis as well. So basically, all these patients, it's a progressive condition. Like there will be a time that they will be having a lot of other symptoms will develop. They are going to lose their what you can say, they cannot self-care, they cannot talk, they become dysarthria, okay. So we must respect their autonomy. When they can make decisions, we must ask, what are the things they want, like how they what about their willpower, will, and all this stuff, okay. So like in the later stages, they may have drooling saliva, they may they may have dysphagia, they may have sometimes pathological laughing or crying, okay. They develop spasticity in their muscles, which can be painful. Mm. Their limbs become weak, they become depressed, okay. They have pain, sometimes like the neuropathic type of pain. So they have like a lot of things. Sometimes they have respiratory symptoms as well, okay. Why? Because their muscles become so much weak over their respiratory muscles, like they cannot breathe even. So like in the late stages, they have difficulty in eating. They may develop aspiration pneumonia, and they can die because of that, because of pneumonia and stuff like this, okay. So there are many famous people who have this thing. So now uh, in the management of this thing, they couldn't found any cure for ALS. Only what they found is one drug. Again, the name of that drug is riluzole. So what is riluzole? It you can say it prolongs survival by just 2 to 3 months, okay. It prolongs survival by 2 to 3 months only, okay. So this is the only drug they found in these patients, okay. So most of the management of this condition is just supportive care we can provide. And like this riluzole is a drug which basically um, increases survival, okay. um, there is one more drug called as edaravone, which shows some survival, like prolongation of survival, that's it. So basically nothing can be done for these people. We have to manage them symptomatically. For example, if they have spasticity, again the same story will come. If they have spasticity, what drugs we can give to them? We can give them baclofen, we can give them tizanidine, okay. Tizanidine, we can give them these drugs, okay. We can give them physiotherapy, for example, okay. We can give them this thing, we can ask them to do exercise, of course, whatever they can do, okay. Whatever they can do, whatever they can do on their beds, okay. If they have too much drooling is basically also called as sialorrhea. So we can give them tricyclic antidepressants, okay. Or we can give them atropine drops to stop their what you can say saliva. Nowadays, one more thing is like we can give Botox injection in their salivary glands. Of course, like they will stop production. So this thing, uh, like simply, whatever they have, of course, we have to treat that. Okay. Uh, if they have dysphagia, we can send them for we can put a gastrostomy tube. Dysphagia, because there can be aspiration, so you can give them put them with tube feeding can be done in these patients, okay. So simply we will keep on if they have depression, so give them antidepressants. So if they have pain, give them painkillers, okay. So of course, like not much can be done for these patients. Basically, we give them high calorie diet. Of course, like they need high calorie diet. If their respiratory function is failing, so we can give them uh, ventilatory ventilatory support. Okay, BiPAP can be given. We can involve physiotherapist, occupational therapist, a speech therapist. Okay, and of course, like they need a lot of support, like psychosocial support. The survival is around 3 years. Median survival from the time of diagnosis to death is 3 years. Like just Stephen Hawking is one of the person, uh, who live a long life, and most of the death causes are a respiratory failure. Simply, guys. Okay, so there are many other degenerative conditions. Um, Progressive muscular atrophy, primary lateral sclerosis, as I told you, spinal muscular atrophy is there. Spinal muscular atrophy is basically a pediatric condition in which there is low motor neuron type of lesion, and most of the babies they die within the first year of life, or max like some who live like they die at second year of life. So, like that's all about this condition, amyotrophic lateral sclerosis. Okay, and when they can make decision, when they can talk, uh, we can plan with them for their future. What about their palliative care? Okay, so that's all for today lecture. Thank you so much, guys.